Welcome to Health Assessment of the Skin, Hair, and Nails by Tammy Valenta. The skin is the largest organ of the body. It is a complicated structure and provides protection, body temperature regulation, and vitamin D synthesis. If any of the structures in the skin are not working properly, a rash or abnormal sensation may result. There are three layers of the skin: the epidermis, the dermis, and subcutaneous tissue. The epidermis is the outer layer of skin. The thickness varies in different types of skin. It's thinnest on the eyelids at 0.05 millimeters and thickest on the palms and soles at 1.5 millimeter. It contains 5 layers. The bottom layer, the stratum basal, has cells that are shaped like columns. In this layer, the cells divide and push already formed cells into higher layers. This is where basal cancers originate. As the cells move into the higher layers, they flatten and eventually die. The top layer of the epidermis, the stratum corneum, is made of dead, flat skin cells that shed about every 2 weeks. There are 3 types of specialized cells in the epidermis. The melanocytes produce pigment, or melanin. The Langerhans cells are the frontline defense of the immune system in the skin, and Merkel cells, whose function is not clearly known. The dermis also varies in thickness, depending on the location of the skin. It is 0.3 millimeters on the eyelid and 3 millimeters on the back. The dermis is composed of 3 types of tissue that are present throughout, but not in layers. The types of tissue are collagen, elastic tissue, and reticular fibers. The dermis also contains many specialized cells and structures, including blood vessels and nerves. The hair follicles are situated here with the erector pili muscle that attaches to each follicle. Sebaceous oil glands and apocrine or scent glands are attached to the hair follicles. The apocrine glands open to the hair follicles in the axilla and groin and are responsible for body odor. This layer also contains the eccrine glands or sweat glands, which open to the skin surface and help to control body temperature. The subcutaneous tissue is a layer of fat and connective tissue that houses larger blood vessels and nerves. This layer is important in the regulation of temperature of the skin itself and of the body. The size of this layer varies throughout the body and from person to person. Begin with old carts, past medical history, family history, and medication history. Once clues from the history and physical exam have been used to determine the overall pattern of the skin eruption, the focus questions might help highlight distinguishing features of the potential diagnosis within each category. When did the rash first develop? Have you had similar rashes in the past? What part of the body did the rash start on? Where did it spread to next? How long does each individual lesion last? Does it seem to be getting better or worse? Is it itchy? Is it painful when you touch it? What makes it better or worse? Have you been putting any lotions, ointments, or creams on it? When we talk about constitutional symptoms, we refer to a group of symptoms that can affect many different systems of the body. Examples include weight loss, fever, fatigue, malaise, chills, night sweats, decreased appetite. Generally, they are very unspecific and will require further evaluation. When taking a medication history, keep in mind that skin rashes or lesions may occur 1 to 2 weeks after starting a new medication, or may even occur after a drug has been discontinued. Make a drug chart and include all meds for 3 months prior to onset, when drugs started and stopped, and is there a history of medication reactions? For the physical exam, you'll need a centimeter ruler, a magnifying glass, a drawing pen, adequate lighting, a flashlight, and a Woods lamp. A Woods lamp, as you see on the slide, is a diagnostic tool that shines ultraviolet light onto the skin. It's useful in detecting fungal and bacterial infections, but must be used in a dark room and may not be as useful if the patient has recently washed their skin. Tangential lighting casts light across surfaces of the body and will make contours, elevations, and depressions easier and sharper to visualize. A complete skin exam includes inspection of the entire cutaneous surface of the body, including the palms, the soles, the nails, the hair and scalp, and the oral, conjunctival, and genital mucosa. When checking color, we're looking for pallor or lack of color, often the color of the collagen of underlying tissue. Cyanosis, which could be central due to decreased oxygen in the arterial blood, or peripheral due to decreased blood flow to the extremities. Or jaundice, and don't forget to check sclera as well as skin for this. Checking for moisture, whether it's dry, sweaty, oily, or clammy, temperature, warm or cool, texture, rough or smooth. Mobility, is the skin mobile? Are you able to lift it? Does it move easily? And turgor is the speed at which it returns to place. When looking at lesions, we're going to be checking the type, shape, color, arrangement, and distribution. On this slide, just be aware of these terms and how they're different. So know melanin, keratin, oxyhemoglobin, and deoxyhemoglobin. As you can see on this slide, we have pictures showing you erythematous and violaceous. The Blanch test is very important in indicating whether a lesion or an area of skin will blanch or not. Blanching indicates erythema from vasodilation, where non-blanching indicates presence of blood in the skin itself. The first step towards diagnosis is to classify the morphologic pattern of the eruption. This entails careful visual inspection and palpation to identify the primary lesion and its distribution, with particular attention as to whether or not the lesions blanch with pressure and whether any lesions contain fluid. A skin lesion is an alteration of the skin. There are two forms, primary and secondary. Primary skin lesions initially appear in reaction to either the external or internal environment. A primary lesion is the basic lesion that makes up a rash. Identifying the primary lesion of a rash is the first step towards identifying the rash. On this slide, the primary lesions are listed with their descriptions. On the following two slides, you'll see pictures of primary lesions. Secondary skin lesions begin as primary lesions and are altered by outside manipulation. For example, a patient bitten by a mosquito develops a wheal. Due to scratching, the wheal becomes excoriated. On this slide, secondary lesions are listed with their descriptions. On the following slide, you'll find pictures of these lesions. The shape or outline of a single lesion should be noted. This slide lists descriptive dermatologic terms used to document the shape of a lesion. The following three slides will show examples of lesion shapes. If there are several lesions, the arrangement of the lesions in relation to each other and their pattern of distribution should be observed. Diagnosis often depends on the shape, arrangement, and distribution of skin lesions. Are the lesions generalized or localized? Is the arrangement discrete, grouped, linear, annular, or confluent? Do they involve certain areas such as intertriginous folds, flexor or extensor surfaces, or acral areas, or are they isolated, regional, symmetrical? The terms for distribution listed on this slide are important to remember because of the diagnostic implications. For example, the parts of the skin that touch when a joint bends are called the flexor surfaces. The parts of the skin on the opposite side of the joint are called the extensor surfaces. This is important to understand when in primary health care too. You will need to distinguish types of eczema and psoriasis based on distribution. The following slide includes pictures of the distribution patterns. Morphology is the form or structure of an individual skin lesion. The following terms are commonly used. Eczematous is characterized chiefly by redness, itching, and the outbreak of lesions that may discharge serous matter and become encrusted and scaly. Keratotic is a skin condition marked by an overgrowth of layers of the outer layer of the epidermis. Verrucous or verruca are warts. Zosteriform resembles herpes zoster and follows a dermatomal pattern. Herpetiform means having clusters of vesicles that resemble the skin lesions of some herpes virus infections. And then maculopapular and vesiculopustular are terms used to describe combinations of primary lesions. On this slide you see three pictures. The first is herpes zoster. This is grouped umbilicated vesiculopustular lesions. The second slide is a maculopapular rash resulting from vasculitis or perivasculitis and may be seen anywhere on the body, particularly on sun-exposed areas, such as the face and upper anterior chest. These lesions are sometimes painful and may also involve the palms and soles. In most patients, they heal without scarring or hyperpigmentation. The third picture is typical of a keratotic lesion, also found on sun-exposed areas such as the back and the arms. This slide lists common dermatologic patterns. See your Tierney text, page 184 through 187, and review the focused questions. This is a great website, so please review this site, do the tutorials, and test your knowledge. Skin lesions commonly associated with aging include cherry angiomas, seborrheic keratosis, senile litigines, and actinic keratoses. A cherry angioma is a very common benign skin growth made up of blood vessels. They are bright cherry red, small, macular or papular lesions. The size varies from pinhead to 1/4 inch in diameter and are often found on the trunk. The cause is unknown but thought to be genetic and very common on individuals over the age of 30. Seborrheic keratoses look like dark, greasy, stuck-on lesions that develop mostly on the trunk. These lesions do not become cancerous. Senile litigines, or liver spots, are clusters of melanocytes associated with sun exposure and aging. They are macular and larger than freckles. Actinic keratoses have the potential to progress into squamous cell carcinoma, the second leading cause of skin cancer deaths in the United States. At least 40% of all squamous cell carcinomas begin as actinic keratoses. If caught early, they're treatable. If untreated, they might metastasize. It is believed that genetics and sun exposure are the main determinants for these. They are characterized by rough, scaly patches, crusts, or sores that range in size from a pinpoint to larger than a quarter, and usually develop on sun-exposed areas such as the face, lips, ears, scalp, neck, forearms, and back of hands. The colors vary from red or skin-colored, brown, gray, or yellowish black. Brownish patches may be mistaken for age spots. The shape may be straight or curved and may resemble an animal's horn. Large patches that resemble a rash can occur when multiple AKs develop. Patients often think they have a rash that will not clear. When assessing pigmented skin lesions, we need to use the ABCDEs of melanoma detection. A is for asymmetry. One half is unlike the other half. B for borders. An irregular, scalloped, or poorly defined border may indicate melanoma. C for color. Color is varied from one area to another, often has shades of tan, brown, or black, but may have colors of white, red, or blue. D for diameter. Melanomas usually are greater than 6 millimeters, which is the size of a pencil eraser, but they can be smaller. E is for evolution, a mole or skin lesion that looks different from the rest or is changing over time in size, shape, or color. Watch this video for a good laugh. It's hysterical. Please review the following dermatology red flags. A pattern injury is a bruise or wound whose shape suggests the instrument or weapon that caused it. For example, a belt buckle, a burning cigarette, pinch marks, bite marks, or scalding hot liquid. Inflicted scalding water immersion burns usually have a clear border, like a glove or sock, indicating the body part was held under water intentionally. The following slide shows pattern injuries, including a scalding water injury. Please document what you see for this slide and the following 3 slides, and bring to your first lab session. When examining the hair, note that vellus hair is short, fine, inconspicuous, unpigmented hair, such as facial hair on women, and terminal hair is longer, coarser, thicker, pigmented hair seen on the scalp and eyebrows. When examining hair, we look at hair distribution and note any patterns of hair loss. Alopecia areata is a common autoimmune skin disease resulting in the loss of hair on the scalp and elsewhere on the body. It usually starts with one or more small, round, smooth patches on the scalp and can progress to total scalp hair loss, called alopecia totalis, or complete body hair loss, called alopecia universalis. Alopecia areata affects approximately 2% of the population overall, including more than 4.7 million people in the United States alone. This is a common skin disease and is highly unpredictable and cyclical. Hair can grow back in or fall out again at any time, and the disease course is different for every person. Hirsutism is male pattern hair growth in women, and is noted as excessive amounts of coarse and pigmented hair on body areas where men typically grow hair, such as the face, neck, and back. It can be an ethnic or family trait or caused by hormonal imbalance. Tinea capitis also causes bald patches on the head. It's caused by a fungal infection or ringworm, is highly contagious, and leaves broken off hairs, pustules, and scales on the skin. This can be seen under a woods light. You can also see in picture the tinea pedis, or athlete's foot, tinea corporis, which is also called ringworm of the body, and not pictured is tinea cruris, which is known as jock itch. Now on to examination of the nails. The nails provide protection to the distal fingers and toes. They grow at approximately 0.1 millimeter per day, although toenails do grow slower, and abnormalities can give clues to systemic disease. Pitting of the nail are small depressions in the nail that are common in people with psoriasis, dermatitis, and alopecia areata. They may also result from nail injuries and can lead to crumbling of the nail. Clubbing is assessed by checking the profile sign. This occurs when the tips of your fingers enlarge and your nails curve around the fingertips. The condition results from low oxygen levels in the blood and could be a sign of lung disease. It is also associated with inflammatory bowel disease, cardiovascular disease, and liver disease. Oncolysis refers to the detachment of the nail from the nail bed, starting at its distal and/or lateral attachment. This may be associated with injury or infection, thyroid disease, drug reactions, reactions to nail hardeners or acrylic nails, and psoriasis. The next picture is Bowes lines. These are horizontal or transverse depressions in the nail. They can appear when growth at the area under the cuticle is interrupted by injury or severe illness. Diseases or illnesses associated with Bowes lines include uncontrolled diabetes, circulatory diseases such as peripheral artery disease, illness associated with a high fever caused by pneumonia, scarlet fever, mumps or measles, and malnutrition. Yellow nail syndrome is often caused by a respiratory condition such as chronic bronchitis or from lymphedema. In yellow nail syndrome, nails thicken and new growth slows, resulting in the yellow discoloration. Nails affected with this condition may lack a cuticle and may detach from the nail bed in places. Spoon nails, or koilonychia, are soft nails that look scooped out. The depression usually is large enough to hold a drop of liquid. Spoon nails may be a sign of iron deficiency anemia. Leukonychia are white spots. Most common type is punctate leukonychia and occurs in normal individuals. The nail plate shows small opaque white spots that move distally with nail growth, and usually they disappear in time. It can be caused by trauma and is also seen in alopecia areata. A type of pseudoleukonychia is a condition known as Terry's nails. The nails look opaque, but the tip has a 1 to 2 millimeter dark band. Sometimes this can be attributed to aging. In other cases, it can be a sign of serious illness, such as congestive heart failure, diabetes, liver disease, or malnutrition. Terry's nails were described by Terry in 1954 as a common sign of liver cirrhosis, occurring in up to 82% of patients. In one study, it was shown that the brown lines were attributed to telangiectasia in the dermis. Onychomycosis is ringworm of the nail. Fungal nail infections are most often seen in adults, but can be seen in children, and they often follow a fungal infection of the feet. Toenails are affected more often than fingernails. People who often go to public swimming pools, gyms, or shower rooms, and people who sweat a great deal often have mold-like infections. The fungi that cause them thrive in warm, moist areas. The following increase the risk of fungal infection: getting manicures and pedicures using utensils that have been used on other people, getting minor skin or nail injuries, having a nail deformity or nail disease, having moist skin for a long time, a poorly functioning immune system, and wearing closed-in footwear.